This is an ultrasound exam of bilateral carotid arteries. This first image demonstrates the origin of the common carotid artery on the right. So we see the innominate, or sometimes referred to as the brachiocephalic artery, dividing into the subclavian artery and the common carotid artery. Common carotid artery here, subclavian here, innominate in this area. Here we see the innominate artery with color Doppler in it. We can see some flow going toward the top of the screen or toward the transducer in the common carotid artery. The color Doppler here is reversed so that flow toward the top of the screen is blue. So blue is the correct direction of flow for the common carotid artery on this image. Some turbulence is seen in this area. This may be due to a rather low PRF selection in the color legend. Here we see some more what looks like turbulence in the innominate flow at the origin of the subclavian artery. Here the signal in the subclavian artery, we have a monophasic waveform with some turbulence. We see flow both sides of the line. This isn't a reverse flow, this is turbulence. So we see forward flow and continuation of forward flow right here throughout diastole. This is abnormal. We should not see this. This is a grayscale image of the common carotid artery in the mid portion. It appears to be filled with a homogeneous somewhat hypoechoic plaque. We see some areas here which we expect are probably portions of the flow lumen. Here we have a signal taken through the flow lumen and we get abnormal flow. We see a very shortened systolic event and even some small amount of flow reversal during diastole, certainly no forward flow at all during the diastolic phase. This is highly abnormal. This is now in the distal common carotid artery, and we see a minimum amount of forward flow during diastole, a sawtooth or a post-stenotic type waveform, and these numbers are fairly low for what you'd expect in a common carotid artery. This is the external carotid artery. There's a kind of a stringy looking flow lumen, so we only see portions of it as it winds in and out of the plane of section. We have a very diminished flow velocity here with diastolic flow. The sonographer has done a temporal tap and sees a response. When we push on the temporal artery, we can oscillate flow in the external carotid artery. It is always better to use anatomical markers to determine whether the ECA is really the ECA, but as a last resort, the temporal tap helps convince us that we're looking at indeed the external carotid artery. Here's a look at the right external carotid artery. It is filled with hypoechoic plaque. Again, little dots of flow as the flow in a serpentine fashion is going in and out of the plane of section. The internal carotid artery has what appears to be some soft tissue plaque, and it's not a great image. There's a lot of shadowing back here from some what is probably wall calcification on the ICA. We put color Doppler on, we see no flow at all. Now, an important technical point, and go back to this previous image, is that if we don't see flow with color Doppler, we should automatically use power Doppler. The flow may be perpendicular to our Doppler gate at portions where a weaving flow lumen enters the plane of section. Power Doppler would certainly help eliminate that possibility. Here we have a pulsed Doppler gate in a portion of the vessel, and we see no flow at all. Now this gate is fairly small. It would make sense to open the gate from wall to wall to show if there's any flow within that larger area being interrogated by the pulsed Doppler. So technically, the sonographer probably moved this gate all over the place looking for flow, but opening it wide, perhaps a full centimeter of Doppler gate would be more convincing that there is no flow in the ICA, that there's total occlusion. This is an image of the right vertebral artery. You can see the vertebral shadows here, and again we have forward flow throughout it. We're probably seeing a little bit of the vertebral vein underneath the arterial signal. Subclavian on the right side, for some reason the color Doppler is not showing up well. The gain perhaps is too low, or although this is a very low PRF, certainly lower, we're getting 120 centimeters per second nearly. We should see color on this image if we're seeing through it with grayscale. So the color Doppler is too low on this particular image. The color gain is too low. This is an image of the left subclavian artery. It appears to be filled with thrombus, but we do see now in color some flow within it. The left common carotid artery appears to be relatively free of plaque, perhaps a little plaque here. We turn on the color Doppler, and certainly there is a small amount of hypoechoic plaque, but it is largely patent. We get a fairly normal signal in the common carotid artery, a little bit of post-turbulent sawtooth pattern to it, but normal flow velocities during systole and diastole. This back and forth motion you see here is probably due to a bounding artery. This Doppler gate is in the middle of the vessel, but it's not in the middle of the flow lumen. If it was moved up a millimeter or two, we wouldn't have the plaque bouncing through the Doppler gate, which is what's giving this signal down here. Image of the distal common carotid artery on the left, perhaps a little bit of intimal thickening here, but no plaque evidence. Well, perhaps a slight amount of plaque. It's hard to tell whether this was frozen during systole or diastole. It's always important to freeze an image during systole. This is when the flow disturbances show up. This is when aliasing shows up. And this is when we get the most sensitivity for determining whether or not this is just slow flow that's outside the range of our Doppler PRF, or whether this is really plaque. Here's a Doppler image. We get normal spectral window. We get normal velocities. However, there is evidence of parvus tardus. See how this curves backward? That shouldn't be the case. It should be straight up and down. So there is evidence that there was disease upstream or proximal to where this signal was taken. This is an image of the vertebral artery. We see shadowing from the vertebral body. We're not seeing a power Doppler signal here. Perhaps the settings are incorrect, or it was frozen during diastole when it wasn't lighting up well with power. But a normal forward flow signal in the vertebral artery. Now we look at the left carotid bulb, ICA junction, and we can see the presence of a stent. The flow in the stent appears to be normal. Again, evidence of parvus tardis. We know this is from flow that is much closer to the heart than where we are now. This void in color flow velocity is probably due to color flow settings and timing of when the update to the pulse Doppler occurred. Here we have flow in the proximal portion of the stent. This is normal looking with the exception of the parvus tardis. Mid-stent, we get normal flow velocities, normal spectral window. It appears good. Distal stent, we have flow now that's 142 centimeters per second. Good spectral window, normal diastolic velocities. Now, the criteria for stenosis in a stent are different than the criteria for stenosis within a natural artery because of the lack of compliance in the stent. The normal cutoff for a stent for minimal stenosis is 150. This is still in the normal range. Remember, for an internal carotid artery, the cutoff is 125. Here's an image of the stent in grayscale, and better still, we have an image with color Doppler and pulse Doppler. Again, we have normal waveform and complete filling of the stent and the distal ICA beyond the stent with color flow. The distal ICA gives a slight increase in flow here. There is a small amount of plaque visualized, and this would be between 1% and 50% stenosis by the criteria being used in most laboratories today. We get further down the ICA, and this waveform has not been measured, but we can see a little bit more of disease and a slight narrowing of the waveform. The angle has been set, and if we look approximately, it looks like we're in a normal range, certainly under 120. And here it's been measured. We get 134 over 54. So again, 1 to 50% stenosis in this portion of the ICA. Here's a look at the where the junction of the stent is and the ICA, and is a beautiful image. Here's the ECA. We see some plaque along the external carotid artery. We have a monophasic waveform, and temporal tap confirms that we are looking at the ECA. So this patient has nearly occlusive disease in the common carotid artery and on the right side, and occlusive disease in the ICA on the right. There's also an abnormal subclavian waveform on the right side as well, and a abnormal left subclavian waveform. The left side contains a stent in the ICA, and the stent is widely patent without evidence of clinically significant disease. There is mild plaque in the distal ICA, and the level of this stenosis is between 1 and 50%. There is also plaque within the ECA on the left side.